MacuHealth is a nutritional supplement leader. Our targeted formulas include MacuHealth for daily eye health, MacuHealth Plus for aging eye support, Vitreous Health for vitreous care, Vision Edge Pro for visual performance in athletes, TG Omega-3 for ocular and systemic wellness, and MacuHealth DM for eye and metabolic support. Call MacuHealth today and mention this podcast for special discounts. Experience the difference with MacuHealth. Nutrition you can see.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. Welcome back to part 2 of my conversation with cardiologist Dr. Mike McConnell. In this episode, Dr. McConnell shares the real cause of heart attacks. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. When we talked a little bit about the coronary artery calcium score, and John, I think his name is Ron Berger, he at the clinic did a study, and he found that 20% of the calcium occupies 20% of the total plaque. So there's, if you do a calcium score, you want 0. So even 0 isn't 100% risk that you're not going to get a heart attack, but close to 0. And as it goes up to 400 or God forbid 1,000, your risk goes way up of having a heart attack within 5 or 10 years. But he found that 20% of the plaque volume is calcified. So that means 80% could be the dangerous plaque that's there that we're not seeing. Now, it kind of explained that to me. So we know 20%. Now, that calcified plaque, is that dangerous? Or is the 80% what's the dangerous plaque that we're not seeing?
Yeah, great question. And, as a side note, I think what's hard as both a clinician, a scientist, a researcher, that, they make you stop adding things to the book at a certain point, and invariably within a year after it's out, there's all kinds of new exciting science. But I think, and you're tapping right into, I think, one of the big developments in cardiovascular disease. So I still, and what I explain to patients, the calcium test, the more we pick up calcium, we know the more plaque you have. And as you said, if we don't pick up any calcium, then the epidemiology says your risk of the next 10 or 20 years of a heart attack or stroke is only 1 or 2%. So it's not 0, but it's super low. And so that's why it's a very powerful test. But you're exactly right from an anatomic standpoint. And it's the same way that, a mammogram picking up some microcalcification in a tumor, it's not the test to image, the total, size and type of a tumor, but it's an indicator. And so the calcium scan is a good indicator. It's a good way to quantify risk. And I mentioned that, the paper that uses numbers, just like you were saying, the highest stage CAC score is over 1,000. So there's the lowest stage is 0, and stage 1 is, between 0 and 100. So we can use it to stage and guide more personalized therapy. But right, the calcification is only part of it. And there are now newer tools, what we call CT angiography. So many people have probably heard of the traditional coronary angiogram or cardiac catheterization, right, where they They go in through a blood vessel in your groin and they squirt a dye into your heart arteries and take X-ray pictures. That's the main thing that they do. If you come in having a heart attack, they'll try to do that right away to open a blood vessel to restore blood flow. Well, now that the angiography can be done just with a CAT scan, you squirt the same dye in, but through a vein instead of having to put a catheter up into the heart. So it's considered, a non-invasive test. We can now do an angiogram, and there are several companies that have developed AI tools to actually measure how much total plaque there is, right? And it'll tell you the breakdown, how much is calcified, how much is non-calcified. There's also what's called sort of low density plaque. So within the non-calcified part, there are parts that on the CT scan have an even lower signal, and that's thought to be where there's more fat or inflammation, the things that I talk about in the book that are more indicating sort of a malignant plaque that's more prone to burst or rupture and cause a heart attack or stroke. So we are just now seeing these AI tools with the CT angiogram that we can fully map out and see, does it look like very stable, mostly calcified plaque, or does it have a lot of non-calcified, particularly this low density plaque that, and Stanford and a few others have started trials that does, putting people on more intensive therapy, now we potentially have a tool to see that we're reducing the non-calcified plaque, we're reducing the low intensity or low density plaque. And so we can actually, right now, the calcium scan is not good for ongoing monitoring because your blood vessels still age and calcify over time. But these newer CT angiogram methods give us the opportunity to see, is the therapy working in you? Do I have you on, the right combination of diet, lifestyle, and medication to start reversing the disease and making your plaque stable so that you don't have a heart attack?
One of the companies clearly is one of the companies. How effective is it? And can you use clearly with a calcium scan, or it has to be with the angiogram, the MRI angiogram?
Yeah, so clearly there's another company called HeartFlow. Um, they both do AI analysis from that CT angiogram. So you can't just do it from the calcium scan because that you need the dye to be able to distinguish. The dye shows you where the blood is, and then that helps you see where, what's the wall of the artery, where the plaque is. And then and then you can use the AI to dissect, okay, this is a calcified part, this is non-calcified, and here's the low density. Um, and clearly is one of the companies that's um, has sponsored a study that Stanford's helping with to look at exactly this. You know, if you manage some people based on just traditional tests like a calcium score versus managing some patients using the clearly analysis, will that lead to fewer heart attacks, better, disease reversal if you use the clearly technology? So those trials are ongoing. We hope to learn, over the next few years. Um,
From clinical experience from you or your colleagues, I think clearly is about $2,000 to do it. Is it worth it? Is it worth 2,000 or 2,500, or am I off on the price?
um, so there are sort of two aspects. One is the CT scan, it's the CT angiogram itself, and then clearly is the software analysis that they do of the images that come from the CT angiogram. So I don't think the clearly part alone is $2,000. I'm pretty sure that's under $1,000. But And we are starting to see that in appropriate patients doing this analysis, that Medicare and some other insurers are covering it. So, yeah, we're close at Stanford to turning on one of these software analyses programs for and we are trying to be very conscious of which insurance a patient has so that it can be covered where appropriate. But yeah, I think it's, as a cardiovascular imager, it's super exciting to see much more detail about the heart arteries and the plaque. But I think we're also a little early in terms of the clinical trial data, as what's the best situation to use it, and is it worth the extra spending that even with insurance coverage, it's still somebody's got to cover the cost of it. So I think we're still learning. I think we're excited about it, but as you said, most calcium scans can be done between $100 and $200, and that's still, to me, the place to start, because we have decades and decades of experience with that, and it's a strong predictor. But that so we would start there, and then in select cases, think whether the CT angiogram and the Clearly or heart flow analysis would be additional help.
Something that's scary is that if you have a calcium score and you really do nothing, it increases 25% a year. And that's scary. And I've heard that even if you use a statin or a baby aspirin, it still increases 25% a year. Is that your understanding as well?
Yes. Yeah. So calcification, how I describe it to patients, basically when you have a plaque there, a plaque ages and calcifies. It sort of hardens and calcifies. So that sort of aging process of the plaque doesn't really slow down because you're on a statin. And in some ways, because the statins, by lowering cholesterol, it actually shifts, it reduces that non-calcified plaque and the low density plaque. So it's improving your plaque, but as part of the aging of the plaque, it's still calcifying. So that's why I had said it's not a good test for tracking whether your treatment is working. It's the great test to say you still have no significant, if you have a 0 score, you're super low risk. When you have a positive score, and based on how positive, that tells you, how intensely we need to start treatment. But then, right, the tool to monitor is, what these research studies are trying to show is tools like a CT angiogram, where you look at the non-calcified plaque and whether that's getting better or worse. That looks like the future way to do it.
Now, how about heart, as a preventive cardiologist, do you use heart math for stress reduction, anxiety reduction?
So I've not incorporated, a stress reduction program in our, preventive cardiology practice, like the one you mentioned. We have had, across Stanford Cardiology, we have had some mental health specialists who've helped with patients either in prevention or in women's health or in our heart failure population, who help work with patients who have higher levels of stress and anxiety. I've not used the specific program that you've mentioned. I did highlight in that section on prevention, when the Heart Association increased they went from Life Simple 7 to Life's Essential 8, adding sleep as one of the things that can impact your heart health. I mean, I did highlight that mental health or stress has been strongly associated with heart disease and heart disease risk. Um, and so, I've advocated that that's one of those additional areas that people should look into, ways to get help to maintain, positive mental health and because that does relate to heart health.
And I
So
know
yeah, I think I had talked about right the things that they hadn't put in the life essential eight, stress, and then alcohol. We had talked about a bit as another one where the data indicates that certainly trying to less is best for that.
how about a carotid IMT? Do you use that for measuring inflammation, plaque as a risk factor for a significant risk factor if it's over one for coronary artery disease?
Yeah, so I haven't used carotid IMT very much. The in some of the large studies that compared different imaging tests to coronary calcification, the CAC score, you know, so there was some very strong head-to-head data that a CAC score is a much stronger risk predictor than um, than the carotid IMT. So, and you know this well, but just to explain to the audience, so IMT is this intima media thickness. So if you look at a blood vessel wall, that's measuring that. If it's thickened, that means you have early plaque buildup. So it's used as a marker of um, your blood vessels are starting to make unhealthy changes. Um, Interestingly, the data that is emerging that is more powerful than sort of just an IMT measurement is actually, scanning the carotid or even in the groin for picking up, discrete plaques. So there was just a paper, Valentin Fuster, who's one of the famous cardiovascular researchers who, based at Mount Sinai in New York, um, they showed, and it's particularly helpful in younger people because calcification, as I said, is an aging phenomenon in your blood vessels. And so it tends to stay zero, particularly in women, until, you're in your 50s or 60s. And so often you want to see, is there something happening earlier than that? And so they showed that, looking for plaque by ultrasound. So again, this is even less invasive, right? There's no radiation. Um, so ultrasound detection of plaque, particularly in the carotids, is a very powerful risk factor. Um, we had done a report about, what's called point of care ultrasound, these POCUS handheld ultrasound devices that can connect to your phone. And so we did a report for the American College of Cardiology on some of the opportunities of cardiovascular POCUS or point of care ultrasound. And one of the sections that I specifically, focused on writing was the use of it for detecting atherosclerosis. And in the European guidelines, for prevention, they talk about either a calcium score or carotid plaque development as a strong indicator for initiating preventive therapy. So it's in the European guidelines, not yet in the US guidelines, but it has sort of a complementary way to look for early plaque development.
There's a ophthalmologist, a glaucoma ophthalmologist, who measures blood flow through the eye through
Mm,
a scan called optodynamometry. And
mm, yep.
if it comes out abnormal, there's over a 70% chance that the patient's at risk for a stroke. And he recommends not only doing carotid ultrasound, but transcranial
Hmm.
Dopplers. And is that something that as a cardiologist you have any experience with? And how is that being more, is that a lot more comprehensive and just doing the carotid?
So, yeah, so I think the first part you mentioned, and I talk a little bit about in the book, some heart disease and effects on organs is related very much to that microvascular function. So we talked about endothelial function, that controls how blood vessels, dilate and constrict. But many patients can have relatively diseased microvessels, so they don't, when our body's saying we need more blood flow, the microvessels can't dilate to increase blood flow. It's like you've got this resistance there that doesn't change the way it's supposed to. And so that's where these flow measurements through your vessels in the retina would indicate you could have microvascular disease, which again, if you're seeing it there, then it could be in other places. We've not used, I mean, I think neurology tends to use more of the transcranial Doppler. An advantage if you're looking farther up into the brain, then you're picking up because the carotid, right, the brain is supplied by multiple arteries. So, and you could have, things could look relatively healthy here, but you could have disease in the blood vessels farther up beyond the carotid arteries. So the more that you can look at, sort of the end part of the vessels and how the flow looks there, the more you can pick up that there could be disease sort of at any place along the way. Um, so, so that's why, but I think it's typically more in the neurology field as they're trying to understand, brain blood flow.
As a cardiologist, I have to ask you this, people listening at home, what are the symptoms for a heart attack? Is it a little different for men and women? And what should people be looking at where they better get their butt to the hospital, call 911?
Sure, great question. So the classic that most people have probably heard of is that you get a heaviness or a tightness in the chest, what we call angina or angina. Um, and I like to explain to people it's right, it's because your heart isn't getting enough blood flow to the muscle. The muscle is trying to work hard. It's not getting as much blood flow and oxygen as it would like if you're having a heart attack. And so it gives you an ache or a heaviness or a tightness. Those are sort of the classic. And then the things that often go with it that are even, part of the concern is it can make you feel sweaty or lightheaded, dizzy or nauseous, or you can feel your heart pounding more rapidly. So those are sort of the classic. Um, but everyone's different. Your heart was not designed to have nearly as sensitive and accurate nerves as your skin. Um, so, for some people, it may not be over their chest. It can be more in the shoulder. It can be more in the upper abdomen. So, heart pain doesn't always localize nearly as well as if you prick your finger in your skin. Um, the other is some people, and this is where, uh, most of the research indicates that women are less likely to have sort of those classic symptoms and more often can have symptoms of just feeling more short of breath or more fatigued. Um, the biggest thing that I always ask is, if anything that feels worse as you try to do more activity, if you try to make the heart work harder and it hurts more, that's much more indicative of a heart problem. But yes, if you've got heaviness, tightness in the chest, particularly if it comes with shortness of breath or sweats, that indicates that you may be having a heart attack. it's best to just call 911 because, as a key part to sort of the beginning of the book was, my father-in-law had sudden death from a heart attack. You don't know how quickly a heart attack can turn into then your heart rhythm goes out of whack. And the only way to recover from that is if, they can shock your heart back into a normal rhythm. So that's why, an ambulance is all set up to get your heart back working quickly. And then they can also, a lot of them now can do an ECG in the ambulance and activate the cath lab so that if you are having a heart attack, then they're there ready to reopen the blood vessel. So, similar for stroke, there are a lot of stroke centers now where they'll can activate a stroke protocol because, for the heart, we say time is heart muscle or myocardium. Same thing for a stroke. The sooner you can restore blood flow, the quicker you can save your brain cells. So that's why if you're concerned, the safest is to call 911, get an ambulance, because they can start treating you right then and there and get the hospital all ready in case it's needed to try and reopen a blood vessel and, save your heart or save your brain.
What do you think about having an aspirin to chew an aspirin if you think you have a heart attack? Is there anything to that?
There is. I mean, that's the first thing that they'll do when you come into the emergency room is they'll give you an aspirin. Um, we talked about how heart disease starts as these growths in the heart arteries, and I mentioned that they can crack or tear or rupture. So really, a heart attack is you have that tissue growth inside the heart artery, but what causes the heart attack is usually a blood clot that forms on top of it when it's has a tear or a rupture. And it's the blood clot because it's happening inside your blood vessel. All of a sudden, your blood vessel is completely blocked, and that's the main thing that causes a heart attack. And aspirin, you know, people may know it helps with headaches and helps with inflammation, but it also inhibits your platelets from sticking to each other. So it's a form of a blood thinner. So that's why it's one of the first things that you do, right? I always keep some aspirin in my travel bag, as well as one of those little handheld ECGs, because it's one of the few things that you can do right then and there. Um, so
At 325, not a baby aspirin, right?
yeah, to get a full inhibition of the platelets, you want to do a full dose. If you're taking it every day, then a baby dose is fine because every day it adds up a little bit. But if you're not on it, the full dose is what you would need right in the emergency situation.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
I think so. Everybody should have aspirin in the house, 325, just in case, God forbid, they have.
Yeah, and you brought up that it's best to chew it because some aspirin are specially coated to have a delayed absorption. So that's why the chewing comes up because that is designed to break whatever coating may delay the activity.
So you were talking about plaque, and I think people get confused that they get a heart attack. Is it because the blood vessels are narrowing, or is it because of plaque rupture? And people can have 90% narrowing before they have any decreased flow. So it really has to do more with plaque rupture, that pimple bursting within the blood vessel. And I read in your book that many new heart attacks that people have less than 50% narrowing, but two-thirds of the heart attacks happen with less than 50% narrowing. But I always notice like when friends and they go and they get a stent or whatever. Oh, I had 95% narrowing, 90% narrowing, 70% narrowing. And they kind of wear it like a badge of honor, but that's not really where the problem comes from. It's from plaque rupture. As far as I understand from reading your book,
Yes.
you explain that to me if that's the case.
Sure. Yeah, no, I think that's a super important thing to describe a bit more. As I said, the main problem, what kills people are the heart attacks. And you can have a plaque, you can actually have a pretty big plaque inside the wall. And one of the things I describe is, your body's natural response as plaques develop is the artery tries to just keep getting wider and wider to keep the blood flow part good. And so you can have a pretty big plaque sort of hiding in the wall, and there's only sort of the tip of the iceberg that may protrude into the blood flow part. And if that plaque gets a tear or a crack or a rupture, sort of like a pimple bursting, your body naturally tries to seal it up with a blood clot. And so that's why in a matter of minutes, you can go from, good blood flow and all of a sudden a blood clot forms on a ruptured plaque, and that blood clot can completely block the artery. Um, and so that's why, um, I have a whole section that doing a stress test is really the wrong test. If you're not having symptoms, the idea that a stress test gives you a clean bill of health is a myth. And we have lots of data. You can have a very positive calcium scan with lots of plaque in your arteries. It's just none of the plaques have yet narrowed, and a stress test only picks up severe narrowings. So that's, to me, that's like you're picking up, end stage malignant cancer instead of we have tools to pick it up at early stage when it's much more treatable. Um, of course, despite all our tools, some people will get narrowings, and if you're lucky, you'll you'll get a heart discomfort, angina symptom without a heart attack, right? The plaque will develop so that you have a 90% narrowing, but it hasn't caused a heart attack yet. Um, some people that won't happen, right? The first heart symptom you have could be the heart attack and could be sudden death, like happened to my father-in-law. So you don't want to wait to do anything until you have chest pain. Um, but the stenting technology, it's most impactful when you come in with a heart attack to try to restore blood flow as quickly as possible. But certainly some people have intractable angina, that getting a stent, can help improve those symptoms. But the stent only treats that part of your blood vessel. So, you still need your doctor to work closely with them to make sure that you're on good therapy. So all the other places where plaque has developed, you can try and reverse that, stabilize that, so you don't just fix one spot and then have a plaque rupture somewhere else that causes a heart attack. So
So we have to find out if we have plaque. I mean, that's the key because there's no
yeah,
relationship, as I read in your book, between the severity of narrowing and how soon you're going to have a heart attack.
yes, yeah. So I mean, I think that was, the initial papers on that started to come out when I was a cardiology fellow, and that just totally flipped my view. My early imaging work was trying to look for narrowings and then realizing that that's way too late in the game. You really need to start looking for when plaque is first developing, because that's when it's, most preventable, most reversible. Um, Unfortunately, it the you know, cardiology, I love cardiology, but we're still very fixated on the stenosis part, and patients get very fixated on it. But there was just a big, the Lancet, which is one of the big European publications, came out with the Lancet Commission that we need to, their statement was we need to move away from ischemia to atheroma. So we need to move away from waiting till something is so narrowed that it's causing, ischemia or angina, and move to we should be detecting atheroma. And they've started using the word that other researchers and thought leaders have used, which is, that's when we could eradicate the disease if we could pick it up at the atheroma stage, not at the, end stage severe stenosis. So that, the field nicely is moving there, but not quickly enough is what I would say.
So these scary plaques, these vulnerable plaques, very stable
Yes.
plaques, test to help us pick up. We talked about the calcium score, LP little a, uh, LP little a in a blood test. How about LP PLA2, MPO, MMPs, oxidized LDLs? Are these good tests to pick up vulnerable plaques? And what am I missing? We talked about clearly before. And what else?
Yep.
What am I missing?
Well, the main one that's in the guidelines is CRP, the C-reactive protein, the high sensitivity C-reactive protein, which is sort of a general measure of inflammation. So you can get a high CRP with an infection or other inflammatory problem, but there is correlation across quite a number of large studies that higher levels of CRP puts you at higher risk for heart attacks. Really where you're, a core to the question you ask, and where CRP is relevant is there is a strong association between inflammation in the plaque and its likelihood that it's going to, be vulnerable to a rupture or a tear. So inflammation, we think, in general, is a good thing. You have these, particularly for heart disease, you have these little macrophages. They're, these white blood cells that go around and try and gobble up bad things, either from infection or other damage to our tissues. So in general, macrophages are a good thing to try and, keep our tissues healthy. It turns out, though, in heart disease and in plaque buildup, they'll try and gobble up a lot of that LDL, the bad cholesterol, but then they end up sort of getting overloaded and they die inside our plaque and they contribute to why plaque, and then that attracts more macrophages. So we have this vicious cycle of inflammation and tissue damage that makes our plaques sort of the surface very susceptible to a tear or a crack or a rupture. And so the treatments that, one example, lowering your LDL bad cholesterol a lot seems to reduce the stimulus for macrophages to come in, and that can make our plaques more stable. But there has been, many efforts to try to develop direct anti-inflammatory drugs, right? So in addition to lowering the cholesterol stimulus, can we directly try to reduce inflammation? I mean, aspirin only has a mild anti-inflammatory effect. So, there have been studies looking at stronger anti-inflammatory drugs, which have had sort of partial success. A big one was colchicine, used for gout inflammation, had a couple of good studies, but then there was one that just came out last year where the data didn't show a benefit. So cardiology is still looking for, what's the best way to tackle the inflammatory part. But the tests that you mentioned sort of go to, are there blood tests that can tell us that there's ongoing inflammation in the blood vessel wall? The LPPLA2, CRP is sort of a general inflammatory marker. Some of these markers of oxidized LDL, which is you're more likely to be oxidized when there's, inflammatory, that's more associated with plaque inflammation. Only the CRP has really been well proven out in large trials, and so that's why it's in the guidelines. The others, are not nearly as predictive as, say, the calcium score for your risk. And then, right, the newest, as we talked about earlier, is looking at non-calcified plaque, low density plaque. There's actually another interesting AI analysis, which is our heart arteries are actually surrounded by some amount of fat. So what we call sort of pericoronary fat. And there's technologies where they're doing AI analysis of the signal within the fat that surrounds the artery that indicates that the fat around the heart artery could be contributing to inflammation in the artery. So there's this marker of inflammatory activity in the fat surrounding the heart. And so that's another potential marker. And that can also be determined from one of these CT angiograms. So I think that, that's where a lot of excitement is for being both better predicting risk of who's got sort of more inflamed, vulnerable arteries. And, where I think the biggest area where we're missing tools is how do we show that, once we get you on a good therapy, that it's working. We want to see the plaque volume shrink. We want to see the high risk part of the plaque shrink. We want to see any evidence of inflammation get less. So, that's really the next phase of how do we monitor therapy to see that, it's having the positive impact that we want.
And is there a way?
Well, that's where, the clinical trials are going on, right? The data does show that we can reduce plaque volume and reduce the more vulnerable measures of plaque. Whether that ends up being, ultimately in the guidelines for how to manage patients to show that we overall improve their outcomes, that's what takes sort of longer clinical trials. But that's why a number of us in the preventive cardiology clinic at Stanford have certainly integrated some of these CT angiogram analysis tools to try and help learn, how do we use them best going forward to help manage our patients.
So let's talk about preventing plaque in the first place. You have Life
Yes.
Simple 7 or Life Simple 8. I think let's start with exercise. How much
Yes.
exercise do we need to do to try to prevent plaquing?
So, yeah, exercise is a topic I've been super passionate about. Part of my work with Google and Fitbit around wearables and how to provide more information to people through their devices. But your phones are good at tracking physical activity too. So hopefully everybody has access to ways to monitor this. So every 10 years there's a big group of scientists that get together to try to say what's the latest data on how much physical activity we need to be doing. And the last two go rounds, the big push has stayed consistent, which is about 30 minutes of either moderate or moderate to vigorous physical activity about 5 days a week. So the idea is to add up to about 150 minutes. And so moderate activity is like a brisk walk. Vigorous activity is a jog. Moderate is sort of doubles tennis, and vigorous is singles tennis. And it's basically,
Where's
you know,
pickleball in there?
yeah, pickleball. Well, a lot of times pickleball is more doubles. So, it's probably more in a moderate. But this is where, the idea is so one of the simple tests, right? If you can, typically moderate activity you can still talk to someone while you're walking, but you couldn't sing. Whereas, right, if you're more vigorous, then you're having to breathe hard, that it's hard to easily talk to someone, as other measures of moderate or vigorous. But right, a brisk walk is sort of the what is the most accessible way for people to do moderate activity. And if you do that, that's about 30 minutes a day, 150 minutes a week. If you really do all, vigorous activity, where you really get your heart rate up, then you actually only need to do 15 minutes a day to meet the guidelines. And this is where, one of the things I and many other colleagues in the physical activity space is, and getting to that longevity, every minute of moderate to vigorous physical activity extends your life by 5 minutes. So you get this huge return on investment. And, in the prior guidelines, they said you need to do at least 10 minutes to get any benefit, because the studies they had only measured in 10-minute chunks. But the latest guidelines, where they had a lot more data from wearable devices, basically said that you don't need to do a minimum of 10 minutes. So every minute counts. So that's why even parking a little bit farther away from your office or taking the stairs, every minute that you can add up. So that was, one of the things we had done at Google and with Fitbit too, is, we try and give you, how many minutes are you getting in that moderate zone? How many minutes are you getting in the vigorous zone? And add it up to, are you getting enough heart points every day or every week? So,
How about
yeah.
diet? You make a big point about the Mediterranean diet, a 30% decrease in heart attacks and stroke.
Yeah, so you can imagine it's hard to do, but there are a couple of big randomized trials of diet intervention, right? It's a lot easier to do a randomized trial of a pill. Um, but there are two big studies where they use the Mediterranean diet, which is trying to be mostly plant-based, low-fat meat, so mostly chicken, and then healthy fats through nuts and healthy oils like olive oil. And right, but and both studies showed um, lower rates of heart attacks. Um, so yeah, and the guidance, whether you want to call it a Mediterranean diet or sort of a mostly plant-based diet, where you're conscious of, because you can even have an unhealthy plant-based diet, right? If your plant sources can still involve a lot of refined grains, and so you really want healthy carbs and healthy fats. Limiting animal meat, healthy fats being healthy oils, nuts, and then more complex carbohydrates. So not, being careful about the typical carbs that are, broken down, that contribute to sort of unhealthy carbs in many people's diets, are, rice and pasta and breads. So that's where trying to stick with whole grains, be conscious of carbs, and then healthy fats, mostly from, non-animal sources. And I mean, I do get in clinic all the time that, right, you need to have protein, you need to have iron, but you can have healthy, plant-based sources of protein and iron, from legumes and other sources. The notion that you can only have a healthy diet if you're having red meat all the time. And I think I probably highlighted that, I've had patients who've gone on a paleo or sort of keto diet and watched their cholesterol, literally double in a matter of months. And then when they go back to a healthy diet, it comes right back down. So, there can be, if you focus purely on weight loss, you could be missing sort of the forest for the trees, that that the consequences of high cholesterol and heart disease are very clear. So um, that's why you need to be conscious about both the healthy fat side and the healthy carb side.
I
And
like I like
typically a Mediterranean diet is one way to do that. That is still very pleasant to eat. So,
I like one of your patients said avoid suicide foods.
oh yes, yeah. He had come in with, he had been ignoring his blood pressure for a while, had a very unhealthy diet, came in heart failure, right? His blood pressure had gotten so high that his heart actually couldn't squeeze against his heart, against his high blood pressure. And so, he started accumulating all this fluid. And so then, he became much more conscious of looking at foods. But then, he would see people pulling, and you brought this, all the processed, ultra processed foods that are in packages these days. And he started recognizing, like, okay, if I were pulling those things down into my diet, that would be like, me committing suicide. So you use that term of sort of suicide food, which is a little dramatic, but for him, it was a motivating way to stay heart healthy. And he's never had heart failure again. And he's had his blood pressure well controlled because he's, been quite attentive to it.
And you mentioned TMAO, from eating too much plaque and inflammation, increasing risk of clot, increasing risk of cardiovascular disease and stroke. Can you mention that? Is that a real thing, TMAO?
It is a real thing. It's actually a preventive cardiologist based out of Cleveland Clinic, who had started discovering that there were components in red meat as well as in some energy drinks that, in the whole era of sort of microbiome, right? Our microbiome is part of how we digest foods, and was finding that a very red meat rich diet would alter our microbiome in a way that would start making more TMAO, which goes into our bloodstream. And then he started doing all kinds of experiments of, what does TMAO do to plaque buildup and atherosclerosis and all you know, the underlying cause of heart disease that we've been talking about. And it, both in animal studies and in human studies, it, was strongly associated with, contributors to plaque buildup, atherosclerosis. To date, we haven't figured out sort of a treatment method. There's clearly the prevention side of then limiting red meat, but um, a big sort of untapped area of research and hopefully contributed to prevention is a better understanding of our microbiome. You know, are there ways that we should be testing and analyzing our microbiome to see if it's sort of heart healthy or not? And what are approaches to modifying our microbiome to make it healthier? I as study said, there are more cells in our microbiome than there are in our human body. So uh, it's still an area that there's a lot of research and opportunity. But this was, particularly compelling, whole, you know, um, really whole panel of research showing that link, a novel link between why, red meat or beef can be a contributor to heart disease beyond just the cholesterol part of it.
And you could do a blood test to see what your TMAO is. And
Yeah.
I don't know if you've analyzed people's blood tests. Most people come out pretty high?
It hasn't become part of our standard panel. I highlighted it in the book because I think it seems like such a promising area of research, and um, it hasn't gotten into the guidelines yet. But I'm hoping that as investigators keep working through this, that We know how best to then, add that to our sort of armamentarium of tools, both for risk assessment and treatment.
As we move through life, simple seven, we did exercise, we did diet. How about vaping and smoking? Is vaping any better or it's just as bad?
So we do think that there are elements within tobacco that contribute to risk of, both heart disease and cancer risk. Um, but the nicotine part in and of itself, um, as a, it's a vasoconstrictor. It tends to want to make your blood vessels constrict. Nicotine itself does have adverse impact on our blood vessels. So that's why, there's, it's a little bit better vaping versus cigarette smoking because you're taking out some of the chemicals that are in tobacco, but it still has heart disease risk. And then just the whole vaping phenomenon, particularly in youth, that there can be other lung injury and other aspects to the vaping itself that are unhealthy. So the American Heart Association, has come out very strongly against vaping in particular because there's a lot of marketing to youth. And so it gets people started early. And then you also, you're reinforcing this nicotine habit, which is what makes quitting cigarette smoking difficult. It's hard to quit because nicotine is a very addictive drug. Um, and so, you worry about getting people on addictive drugs at a young age and all the adverse health consequences that come from it. So, uh, you still really want a well-constructed program around smoking cessation that, sometimes uses an intermediate phase of some, nicotine replacement as you try to titrate and wean people off. Um, so, so I think in a structured program, using non-tobacco sources of nicotine to help people wean their addiction can be helpful, but certainly don't advocate, vaping as a solution for cigarette smoking. So.
The next is sleep. People with apnea, they have an increase in adrenaline and causing their heart rate to go up. Talk to us about that.
Sure, yeah, so sleep apnea is typically people have periods overnight where apnea means you're not breathing. So they have periods where they're not getting, full breathing. Uh, and right, your physiologic response, your adrenaline is going to go up because it says, I'm not getting oxygen. That puts stress on your blood vessels. So sleep apnea can be a contributor to high blood pressure. Um, it's also a contributor to a syndrome called pulmonary hypertension, which is increased blood pressure in the arteries that come out of the right side of your heart that supply your lungs, the pulmonary blood vessels. And so high blood pressure there puts strain on the right side of your heart. So you can get pulmonary hypertension and heart disease from that. And then it's also a contributor to atrial fibrillation. I talk about, this abnormal heart rhythm that, in general, you become more likely to have as you get older, but sleep apnea is a contributor to increased risk for that. Healthy exercise begets a good sleep, and then a good night's sleep helps you be prepared for a healthy exercise. As many people probably know from personal experience, when you have very disrupted sleep, it disrupts your whole eating, routine for the day. So people are more likely to have unhealthy eating patterns when they're not sleeping well. So all of these, tend to interact, which is why the Heart Association added, getting a good night's sleep is important for prevention because it's sort of intermixed with all the other healthy things we advocate.
We talked about alcohol, but pretty much no alcohol is good. How about coffee? Good, bad, or
I
indifferent?
mean, interestingly, I mean, I'd say, overall, there isn't strong data either way. I mean, there are studies that show, having regular coffee in some studies seem to, in the long term, reduce your risk of heart disease. Um, there's sort of mixed studies on whether caffeine helps because it's a mild stimulant, as people may have experienced. If you have a strong cup of coffee first thing in the morning, you can feel your heart rate go up. We usually tell people don't, if you're going to check your blood pressure as to what it would typically be, don't do it. Don't have your cup of coffee until after you check your blood pressure. So it is a small stimulant.
Let me ask you a
And
question about that. Because if it is going to raise your blood pressure, that's not good. So if we test it after you have the coffee and it raises and you have 5 cups of coffee a day,
yes,
that can't be good, right?
you're right. Yeah, what I'm sort of reinforcing is probably in the guidelines that have used your home-based blood pressure to sort of monitor the effectiveness of your therapy. It's sort of based on doing the measurement before you take your medicines and before you exercise, before caffeine. But that's why there is a lot of interest in having a more continuous blood pressure monitoring device. The big interest in a lot of the wearable companies of can we have a more, we can look at your heart rate continuously now, and so we can pick up atrial fibrillation through your watch. But we've yet to really have a good, wearable blood pressure monitor, without the cuff squeezing. So, yeah, the best measure is a true 24-hour assessment because then that takes into, all the things you may be doing throughout the day and, how much your blood vessels respond in a good way or a bad way
We need
to
an
those
A,
things
we need
you're
an
doing.
A1C for blood pressure.
We totally do. Yeah. I mean, that's where maybe the, retinal images and the artery vein ratio in some ways you could think of as a longer term measure of, how our blood vessels are responding to blood pressure.
As we finish up, I have to go through the last three: cholesterol, blood pressure, and blood glucose.
Yeah.
Cholesterol. Does the body make cholesterol to try to kill us?
It doesn't make it to try to kill us. Our body does make cholesterol, and it has a healthy function. Um, but when we're born and we're making cells like crazy and we're growing like crazy, our LDL, our bad cholesterol, is only about 60. Uh, so we don't. But the average American adult has an LDL that's like twice that. Um, and and there's lots of other studies that our closest primate, evolutionarily primates, typically have LDLs similar to what we're born. Or if you look at, there are few communities of humans that are still the hunter-gatherer that haven't been exposed to modern ultra-processed foods and lifestyle, and their LDLs are super low. Um, so, uh, so yeah, we do use cholesterol. Our bodies use it, but we really only need, a much, much lower level than what we're typically walking around with. So you know, that's why the latest guidelines, for the highest risk patients, the guidelines are to get our LDL below 55, right? And most people are walking around closer to 110, 120.
And
So
how about fractionating the cholesterol with the small particles and the big particles? And is it really the cholesterol, or are we really we really have to measure the lipoproteins, and the cholesterol is the easy way to measure the lipoproteins, but the lipoproteins, the small ones, are really the dangerous ones.
yeah, so this is where I do try to highlight sort of what's now emerged, is measuring ApoB. Um, because the the focus on LDL has been appropriate in that LDL is where it's sort of the size range of the particles where most of the bad particles are. But you're right, it doesn't tell you how many particles, it just sort of tells you the total mass of LDL. And so you can have a lot of smaller particles or fewer large particles. The ApoB actually directly measures the bad thing, which is the ApoB is the main marker of a bad particle. So when you measure the ApoB level, it tells you how many bad particles there are. And there actually can be some bad particles that don't fall into the LDL group. So it has a double benefit. So I that's now, it's highlighted in the European guidelines. We expect next year they'll have the new cholesterol guidelines, prevention guidelines in the US should come out next year, and expect that ApoB will be highlighted there. I mean, in many patients, there's a rough correlation with LDL, but the studies show it's a better risk predictor and a better way to track response to therapy. And the latest article is basically the same. If a high risk patient, we're trying to get LDL below 55, then we're trying to get ApoB also below 55. If you can get both numbers below their target, then that's really the ideal.
Because my understanding is with the small particles, they hang around for about 7 days. They can get into the gap junctions and get inflamed. But if you have a lot of big, fluffy particles, they only last for 7 days, and they're not going to get into the vessels and get inflamed. So is that is so the ApoB or the fractionating, the NMR, may be a better way than just doing straight LDL? Is that something that cardiologists are starting to agree with?
Yeah, I mean, have been a couple of big publications in the cardiology journals that we should be moving away from LDL as the primary measure to using ApoB. And that's why it's featured in the European Society guidelines, European Society of Cardiology guidelines, and we expect that it'll be highlighted in the next, US-based cardiology prevention guidelines. It also has advantages that it's a more reproducible, reliable test than the LDL measurement. And as you know, a lot of the sort of labs, the typical LDL measurement is a calculated number, not a direct measurement. But it'll probably take some time to shift over to the ApoB, right? I've been getting it, so I get more experience with how in individual patients the LDL and the ApoB is comparing. But my goal is to make sure both are well controlled, because the ApoB does take into account that if you have lots of small particles, the LDL may be okay, but the ApoB would still be high. So that's why I've started using that in my patients.
And you talked about the C-reactive protein, about inflammation. Peter Libby's, who really was a big proponent of that. How about the Jupiter trial that looked at that inflammation may be more important than actually cholesterol itself?
Yeah, so this is one of the large cholesterol lowering trials, and the interesting thing is they looked at people's LDL actually didn't have to be that high, right? So you could have what was considered sort of a typical LDL level. But the biggest benefit, was or sort of the highest risk group were the people who had the high CRP. So you could have what would otherwise be considered sort of a relatively normal LDL level, but you had a high CRP, and then if you went on lipid lowering therapy in that trial, then that CRP indicator was a big flag, and then it showed you had fewer heart attacks and strokes. And there have been some additional analyses beyond that really the group that ultimately does the best are the ones who, you know, have both a drop in LDL and a drop in CRP. So that's why it's still, a part of the guidelines as what's called a risk enhancing factor. So if you still have high CRP, that may indicate some what we call residual risk. So you know, some numbers may be better, but if the CRP is still high, then that advocates for continued sort of trying to do more intense therapy to reduce that risk.
And where do triglycerides fit in? Are they worse than LDL, same, or not as harmful?
They're overall not as harmful as LDL, and we they are another what's considered sort of a risk enhancing factor, like the lipoprotein little a and the CRP. That if you have high triglycerides, one of the ways to assess high triglycerides is they contribute to what's called the non-HDL cholesterol. Um, so non-HDL is sort of the combination of the triglycerides and the LDL, sort of the bad part, the bad part. Um, so we look at non-HDL cholesterol as a marker of how much the triglycerides are contributing. Um, so uh, and there are now some additional in the very high risk patients, there are some medications focused on helping to lower triglycerides that have shown additional benefit beyond just the LDL lowering. But I think the other thing that's very promising is high triglycerides are very much associated with sort of metabolic health. And so, weight loss, increased physical activity, limiting carbohydrates, so many of the things that can help your overall metabolic health can help lower your triglycerides. So it is one of the factors that's probably, quite amenable to if you're metabolically unhealthy, that's an area that can very much improve um, with things that you can do to improve your metabolic health.
The things
Um,
that we talked about to control lipids, the three things control cardiovascular, the three main ones were lipids, blood pressure, and glucose. We talked a little bit about blood pressure in episode one, but do you want to mention anything else about blood pressure?
Yeah, so it is worldwide the number one most sort of modifiable but risk contributor to disease, so both heart attacks and strokes. Um, One of the things that I highlighted in the book was, if we can detect things earlier, so we talked about retinal imaging as one way to pick up changes in those vessels that indicate either current high blood pressure or risk for high blood pressure. It's one of the things that, at Toku, we published on retinal changes in hypertension related to increased risk. And even our biologic age assessment is associated with higher blood pressure. Um, but it is, many of the heart healthy interventions that are done to improve your metabolic health. So I talked about the diabetes prevention program, more physical activity, healthier diet, some weight loss. Those same interventions helped lower the risk of progressing from sort of pre-hypertension to hypertension. So it is an area where there's a lot we can do. Yes, they're both, medications to lower blood pressure, but heart healthy activities that are part of Life's Essential Aid or part of the diabetes prevention program um, can help lower blood pressure. It's a promising area too with the new GLP-1 medication. So I have some patients where, we've sort of maxed out on some of the standard blood pressure medicines of controlling their blood pressure, but with a GLP-1 to help bring weight down. we're seeing improvement in blood pressure. So I think it's an area where we have both lifestyle and sort of a range of other things that you could, work on to help either help prevent getting hypertension in the first place, or even if you get it, to reverse it or get it under good control.
And how about blood glucose, CGM? You talk about CGM and the importance of that. If you could explain how that can help our patients.
Sure. So that's a continuous glucose monitor, the CGM, and it's not. It has this microscopic needle, so when you put it on, it's sort of like you give yourself a little slap on the arm. It's been critical for helping type 1 diabetics with insulin pumps to manage. So you have this nice closed loop system to control their blood sugar. But I think how I've used it in prevention, both in my own, testing it out and then in patients, it gives you very direct feedback about what you're doing in terms of diet, or, what you're eating, and does that make your glucose spike? So I think it's a great learning tool. So you don't, not committing to using it all the time, but using it for a week or two, testing out, seeing what aspects of your diet are contributing to spikes in glucose that are probably giving you, contributing to your metabolic health. So I think it's a great learning, and it really helps personalize, your own understanding of, how you can make modifications to your diet and activity to improve your metabolic health and ultimately your heart disease prevention.
Let me just end this show. So I want to thank Dr. Mike McConnell for joining us today. His book, Fight Heart Disease Like Cancer. Pick up his book. It's a great book. I read the whole thing. And if people want to find out more about you, how could they do that?
So there is a Fight Heart Disease Like Cancer, fhldc.info. So that website has a lot more information about the book and about me. You can also, if you go to the Stanford website, you can look up my profile that has sort of my background and the work I've published over the years. And then the retinal imaging company is Toku. So if you look up Toku Eyes, our website is there, and that talks about the products that we have, what's deployed in the US now, what's deployed overseas, and what we have coming next. So yeah, it's a great pleasure to talk to you. Thanks for the opportunity. Stay heart healthy.
Thank you, Mike. I really appreciate it. And thank you for giving us extra time. I know we went over. You're a real gentleman, and thank you for helping people out there.
Okay, thanks. Thanks so much. Take care, everybody.
MacuHealth is a nutritional supplement leader. Our targeted formulas include MacuHealth for daily eye health, MacuHealth Plus for aging eye support, Vitreous Health for vitreous care, Vision Edge Pro for visual performance in athletes, TG Omega-3 for ocular and systemic wellness, and MacuHealth DM for eye and metabolic support. Call MacuHealth today and mention this podcast for special discounts. Experience the difference with MacuHealth. Nutrition you can see.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not
Right, exactly, not
multifocal.
multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.